Hi, everyone, and welcome again to another VITA Academy webinar. Today we're featuring Mr. Mark Wagenfield. Hi, Mark. How are you doing?
Good morning. Super duper. How are you?
Excellent. Excellent. Thanks for joining us today. As many of you know that have watched Mark in the past, get ready for an exciting webinar. We'll have your attention at least for an hour or so, and then we'll do some Q&As. Mark is going to talk about the complete upper denture against natural dentition, lower natural dentition. Before we get going, though, just a couple things here. Everyone's phone is on mute, so if you have a question during the program, if Mark brings something up that you controversial, like he always does, elicit some comment and some feedback, use that question box on the panel on the right-hand side of the GoToWebinar panel, and then send those, and then we'll save those to the end, and we will ask those questions away. We will also going to record this video, or this webinar, I should say. You'll find it in a couple days on the VITA North America YouTube channel. We post all of our webinars, all of our short videos, how-to videos on that platform. So please visit us. And then we're going to open it up here to Mark as soon as I introduce him. Mark Wagenfield is a denturist, VITA Global Certified Trainer and Management Consultant for VITA, a licensed denturist and dental technician with over 35 years of experience and growing like I am, getting more and more years. Owns and operates Heritage Denture Center in Edmonton, Canada, his own clinical denturist practice. Mark has spent his career focusing on how dentures integrate in the mouth and body. He inspires a unique awareness of occlusion and professional growth of technicians, dentists, and other denturists. Mark's perspective is coming again, he's being a denturist up in Canada. He's got a lot of practical clinical experience as well. So he'll bring a little bit more objectivity as far as for technicians here in the U.S. that don't get to see the patient, don't get to put their hands in the patient's mouth and so forth. Mark will make that a little bit more of a reality for you so you can understand all of the concepts and so forth. So with that said, I will let Mr. Mark, I will let you take it away. So I am going to make you the presenter at this time. You are now the presenter.
Okay, I have assumed control. Okay, 1 minute, everybody.
A lot of power.
I know, it's all gone to my head, Jim. Thanks to VITA North America, thanks to Jim for their very kind support of our professions, being denture professionals. I'm very grateful to VITA North America and to VITA Germany for their kind support in supporting us and supporting these types of courses. When we share, we grow. So we're sharing information. Let me clean the screen. There we go. We share information and we grow and we learn, and that's what this is about. It's a safe environment for us to share our experiences. We're going to get right down to business here, and I'm going to set up an immediate upper denture to lower natural occlusion and provide you some tips and some experiences during my journey. And that's what this is me sharing my journey, trying to be a superhero to a patient, and especially on immediate dentures. They're troublesome and they're hard for patients to adapt to, and we garner the most complaints on them, and not the complaints clinically when they come in for an adjustment, but complaints to the professional governing bodies that govern us. So for example, the college here in my province of Alberta usually gets quite a few complaints on immediate dentures, ranging from fit and such expectation levels of patients. So before we get started, I wanted to share this. And here's what I speak to when I speak to a patient, so that we prep them. So number one, this is about quality of chewing life. They're in my office for a reason. The decision's been made to pull their natural teeth. So this is about quality of chewing life and then quality of life underneath that. You have to eat to live. So quality of chewing life is there. There's a couple things to remember. Number one, there is no nerve into the denture teeth. There is a nerve into your natural teeth, regardless of the state that it's in at the time of it being extracted, there's a nerve. And your central nervous system has an impulse or an imprint of where that tooth is. That's going to be cut. Your brain's going to go, hey, where did that thing go? And then all of a sudden it's not there. Then we're going to shove a denture in your mouth that sits on the gum. So what that does is the denture creates hydraulic pressure on the gum. So when the gum heals, your brain's going to learn to understand what a denture is and what this thing is pressing on the gum structure. So when you swallow, your teeth will touch together. There will be so much pressure exerted onto the ridge. When you chew, there'll be more pressure. So your brain will start to understand the pressure differential between swallowing or hanging out to chewing. So that's how it tells that the denture is functioning and is under function. I like to use the comment, it's like walking without feeling your feet. We're going to ask you to chew without feeling your teeth. Because again, remember, there's no nerve into the denture. So I have found that being very, very helpful and poignant to explain that to a patient when they hear that information. They have to understand what's coming. The other thing is to say at first, your gum will be very wounded. And so what'll hurt first is the wound. The denture is there to act as a compression bandage over top of that wounded gum. It's there to help control bleeding, control swelling, and shape it. So it's not expected that you're going to eat anything for at least 2 to 4 weeks, depending on the situation. With that said, you'll be on a liquid diet. After that 2 to 4 week period, you can expect to just stay on very soft things like ice cream and puddings and such. I always remind patients, you also have to remember there's ground beef, ground pork, tofu, ground turkey. You can just, make that with hamburger helper and mash it with a potato masher. You don't want to begrudge yourself the things that you like. For example, this last week, I had a patient say, Mark, can I eat Kraft dinner? Yeah. If you're hankering for Kraft dinner, please go eat Kraft dinner. Just, again, cook it, mash it, so that you really don't have to chew. Because what the chewing does is the chewing's creating the hydraulic pressure on the gum. The gum is still wounded and not healed enough to accept that. So then it's going to harm it or potentially damage it or wound it some more. So then patients understand that. I have, again, found those types of lines of information very, very helpful in me helping. What I like to say to the patient is the denture integration into your body. Remember, at the end of this day, once things heal in 3 to 6 months, your brain has no nerve into that denture, and we're asking you to, again, walk without feeling your feet, chew without feeling the actual teeth. And your brain will figure it out. It'll figure out how to do it. It'll figure out the pressure changes, but the gum has to heal. And then I say to them, importantly, the nerves inside have to heal to be able to accept the load from the hydraulics of the denture. So I wanted to share that with you before we get started. Really, really important. It has been very, very successful for me to, again, understand, for the patient to understand what they're getting into, the expectation levels of what they're getting into. And I always tell them, this is about quality of chewing life, the lights at the end of the tunnel. Yes, you're going to be frustrated during this. It takes time to heal. Now, we're going to get started. So let me get the light on here. So we have an upper denture, or excuse me, an upper model. Let me see what works better here with the light or no light. We're going to go no light. And we're going to go into focus. Yeah, now let's try it with the light on. Okay. couple things on this. The first thing we're just going to get started is just some general points. Look, immediate dentures, I picked this model just so that it's a full upper denture. You'll have some teeth missing. As we know, everything is all over the board. But what we want to do is first point out a couple of key points for us, regardless of the condition, regardless of what teeth are there and such. There are some things that we can learn and watch for. So the first thing we're going to do is a quick model analysis. So on this, what we're going to do is I'm going to point out where the long branch rugae is, and that's this one right here. And the long branch rugae comes up like that. Okay, so it's like this. This one kind of has a little bit of a split in it. So there's almost like two of them there. So what happens is when you circle the long branch rugae, the long branch rugae points to the cuspids. So that later when I remove the tooth and put a denture tooth in its place, I know I'm trying to reproduce the golden proportions of this. So the long branch rugae always points to the cuspid. So then that gives me a reference of where this should go, even if it isn't there and has already been previously extracted. It still is a reference point of where the long branch rugae and where the cuspid goes in relation to the long branch rugae, and that golden proportions this out. Because in our skull and in our face, everything is golden proportioned, meaning the size of the teeth, the width of the teeth, the placement of the teeth, everything gets golden proportioned within our face. We want to maintain the dentures and the denture teeth within that. The other thing to keep in mind is that the VITA, Excel, and linguiform teeth are golden proportioned as well. So they do follow golden proportion rules. So you have to think of, Michelangelo's David and the pyramids. Everything was golden proportioned with art. And that's the same thing here, is that we're golden proportioned and we want a denture that's golden proportion. The other thing that we're going to do is we're going to scribe into the post-dam. So I'm actually going to be scribing a line right about here. Now, it's easy for me to see this because I'm live, and when we do a live in-person course, you can usually tell it on the model. But if you see where I drew my line, there'll be a slight little indent. You'll be able to, like a little raised, think of it as a speed bump sometimes. They're faint. Sometimes you see, you can just tell. So these work out well when the tissue is not compressed when the denture impression is taken, or excuse me, when the master impression is taken, and those pop. So I'm going to just draw them out by pen, and then what we're going to do is we're going to be scribing our post-dam, and our post-dam will feather in here, and then what we're going to do is we're going to kind of do this with our post-dam. And then again on the model, you'll see this is a little bit of a puffier area right in here. And we stay away from this because this is the bony little part that comes. So the post-dam actually looks like a butterfly, almost like a feather. And the reason for that is this. I'm going to just change my camera angle here, so forgive me. And I'm going to introduce everybody to Gustav. So yes, I named the skull. His name is Gustav. Hi, everybody. So Gustav is, this isn't a real one. This is a plastic, but it is a true to scale version of the skull. You can actually find these online or at medical stores. They're awesome to have. I've actually pulled them out in front of patients to explain things to them too when necessary. So what Gustav will do is we're going to flip them over. And we're going to come into the palatal area so that then I can highlight a couple of things here. So number one, you can see this is, as I refocus, this is that little puffy part on the gum, okay? So right in this area here is the puffy part on the tissue that I just saw. And then with Gustav, you can see there's that little bony area there. So remember when I drew that pencil line? That's where I'm trying to go, is right in there. You can just see there's that little raised area. So by me studying true to life skulls, so over my time, I purchased this one, but I've seen other true to life skulls and renditions of the skull. And I noticed, wait a minute, this exists in the palate. and this exists here for the post-am. So I model my post-am after this because this is the bony areas and the skeletal supporting it and the golden proportion rule supporting it. So that's why I scribe and make my post-ams this way. So I'm just going to grab. So basically, you just want to take a little scraper, and it's just one line like that. So it's just one motion on the side here. So it's almost like it's a very, don't want to go scribe it hard. It's only maybe a quarter millimeter in, half at best. It's just a small little line in there, and the reason why you do that, it's almost like a horizontal bead seal that we're putting in. I've never had to adjust these out. And I'm going right where that bone is, and I said you can sometimes really follow it even on the model. It's quite accurate. And then here, what we're going to do is we're going to scribe in the post-am. So I scribe along the top little hump here, and then I just gently go a little bit deeper, maybe about a half a millimeter in. So that's now pushing into what I showed you on Gustav with the bone. And then I'll just kind of bring it up just a little bit, and I'll come across. This is the bony area in here, so I don't want to put anything, no scribing in there. And then I come with my other half moon circle here, coming up, and that's my post-am. When I started to do these types of post-ams, my adjustments on post-ams virtually came non-existent. This has been very effective in the seal. And then I'm mimicking this after, as I said, Gustav and what the bone is underneath this. So I know that some, gosh, there's so many different kinds of post-ams, but typically we see that real heavy notch here. I don't do that. It's a very subtle kind of a butterfly approach. So again, we have this vertical, or excuse me, this horizontal, this comes up like this. Okay, and it looks like that. So I ran out of a little bit of the model, but sometimes even I have a little tail on my dentures. So again, that's also mimicking Gustav as I bring him back into the picture here. So you can see what I'm doing is right in here. So I'm actually putting a little tail on my dentures as well. So I don't have a finished denture to show you at the moment, but I like to put that little tail on there, and that's where that came from. So that was just me looking at the anatomy on the skull and trying to, again, incorporate that into the denture. Okay, so we're gonna get these articulated. I'm using a Cavo Protar articulator here in the office. I'll take the pin out, okay, and we're gonna follow along as I set this up. Look, at the end of the day, when you use whatever kind of articulator for anyone, there's a couple things that are going to become prevalent as I'm looking for space to put things. Regardless of what you do, when you look at the dentition, you can see where patterns exist. So this was one for a partial, but at the end of the day, you can see when we come up close, and I'll take the light out and we'll do the focus. You can see there's a wear pattern here. And when you hold that against the upper, or excuse me, it was right here, pardon me, this one. And when you hold that against and see it, you can see the wear of the tooth. So as the person's chewing, things have created a wear pattern. And what that does is that lets me see the chew cycle of the patient. So in previous webinars, you hear me say that we typically always check the articulator like this when we do something. And I say don't do that. What you want to do is actually facilitate them chewing. So a chew cycle is in a teardrop pattern. So what I'm doing is I'm then following a teardrop pattern, but you can see how there has been some wear pattern here. So what I'm doing is I'm observing these wear patterns on the natural dentition before I do anything, regardless of the articulator. So coming back to Arcavo articulator, and when we look, you can see there's a wear pattern on that upper cuspid. So right there, there's a wear pattern here in relation to this tooth, so that I know now when this person's going through their chew cycle, there can be a pattern. So I'm not just strictly mimicking it this way, I'm actually going to follow a chew pattern of this patient based on the wear patterns that I'm seeing in the dentition. Now, when I see a patient, I can determine their chew cycle or what their teardrop looks like by examining them and watching them speak. As a technician, we don't have or are not afforded that opportunity, but you can see it on the model. So what this means is I want to remember that, and I want to note those patterns, because that's telling me, okay, this one maybe has a little bit more of a horizontal pattern because there's these wears there. If there's no wear pattern, then it's a more vertical or a more teardrop type of chew pattern. And if you see a lot of wearing of the dentition, then I know they were going a little bit more horizontal. So that then when I set the denture teeth, I want to mimic that. So that I mimic it. Why? So that it fits better to that person's chew pattern. It's like, again, shoes that match that person's walking and their stride. This is about mimicking their chew cycle. So if you see the patient, you can identify it. If you don't see the patient, I'm looking at the teeth to see it myself, to then ascertain, okay, what kind of pattern, how am I going to move the articulator? Not just like this, because that's not how it works in the mouth and in the skull. It's how's that pattern? So then I can make sure that I do the pattern more in line to that patient, so that the teeth and the cusps function. Because what I'm trying to avoid then is the guiding planes of the teeth hitting on the bottom. Just because it worked here on the articulator when I made the denture, I just did it in my typical, excuse me as I have to unlock everything. So when we go through and we just do a standard motion on the, for example, we just do that typical motion on the articulator, that's not actually an indicative of what the chew pattern is once the patient's starting to eat. So what I'm trying to do is, I said, watch the teeth, look at the wear patterns before I start the denture, and then mimic that, so that then I can make those adjustments on the denture teeth, so that then this thing functions better once it's completed, and then it's going to sit better and create less adjustments. This is all about controlling the adjustment rate. And this is what's important as a denturist or as a dental technician. You're trying to control the adjustment rate so that the patient isn't coming back as much because the denture's tipping, it's dislodging, it's moving, etc. You're trying to get it so that it fits within the chew pattern of that person. So it's controlling the adjustment rate, because everyone, I'm going to tell you right now, adjustment rates are expensive. They are deadly. You have to keep in mind, if a busy practitioner is doing 4 or 5 adjustments a day, they are anywhere between 20 to 30 minutes in length. When you do the math on that, that's a lot of time lost in a day, non-productive time. So when you can follow this and control your adjustment rate and bring it down, you're more effective, you're more efficient, and you're not bogged down with repetitive adjustments and trying to squeeze them into a busy practice day, because that also creates stress and that creates burnout for us. So this is also about controlling quality of chewing life for the patient, but quality of life for the practitioner. So as a dental technician, you're supporting the dentist. Dentists and dental technicians have a symbiotic relationship. It's almost like they're married, because if one fails, it affects the other, and vice versa. If the impression isn't good, if the bite isn't good, that affects what the technician does. And if the technician makes an error in the setup or such, that affects the end product that the dentist is trying to deal with in the mouth. So it's very important to understand that what we're trying to do is always support the end goal, which is the patient and their ability to chew with the denture. So what we're going to do then is we're going to start. So I'm going to make some noise and we're going to start whacking some teeth out of here. couple things. Number one, you do not want to touch the incisive papilla. So make sure when you're grinding, you are not hitting the incisive papilla. Okay, you want to leave that sucker alone. Okay. Now there's much debate as to how much do you grind off and what's appropriate. This is also about, you know, the what's the shape of the teeth and the gums. If we know, are they infected? Is there issue? Because there can be quite a bit of bone loss and gum loss depending on the health of everything when the teeth are pulled. So you do want to put a kind of a cavern in here. You want to watch these because typically you want to smooth these out a little bit. Depending on how the extraction goes too, we'll get a bony edge here, which will cause some sores. As I said, you want to just make sure that you do not touch the incisive papilla, leave that sucker alone. The other thing to keep in mind, and what I like to do is to circle and actually draw these. These are the cuspid eminence right here. Typically, we see a lot of sores on this post-insertion. So you have the wounded tissue, but then you get a sore here up on the flange because this is very bony. You can feel it on yourself actually, and you can even see the bone structure here. Look at that, it's even popping out. So what I'm gonna do is post processing, I'm gonna take a round burr, a larger round burr, and I'm gonna hollow this out a little bit in these areas because I know they're bony. So what I'm trying to do is just release some of the pressure here post insertion. So I wanted to bring that to your attention as well. So the next question that always comes is, you know, how do you set the teeth? So this, again, on this setup, we have some character. So if the patient wants to make everything pretty and not have any misalignments or moved teeth or turned teeth, we can make that correction. So I'm going to put a little bit of wax on here, and I'm going to grab my VITA Excel, and we're going to start the process of laying it in. And so we're trying to take one tooth off, put one tooth in. We're trying to keep it within the golden proportion rule and where they're at. If there's been drifting of the teeth, then as I said, what helps me come back to center it into the golden proportion rule is the rugae and where that sits on the rugae to help so that I can kind of bring things back into line from the perspective of the golden proportion rule. Okay. So a lot of times when we do this, we're faced with a lot of grinding. And so we value our fingers and our skin. So the object is again, we're trying to take the tooth out, put the denture tooth roughly into the same position unless we wanted to physically move it because it drifted or such, or there's a cosmetic reason for us to make that change. Okay, so we're going to lay that in. Okay, and we're going into the same position. So what I've done is I've did model analysis, I've marked the rugaes, done my post-dam, inscribed my post-dam. I've checked then the occlusion to ascertain and look at the chew cycle and the movement of that patient and what I believe it to be. Then I'm going to start the process of removing the teeth. Again, over the years, like I said, I like to give that hollow where the root tip was, because again, that little raised area on the denture is going to be helpful to help control bleeding and put a little bit of pressure on it. So that's why you want to put that little socket, the divot in it. And we're going to go in and set the teeth. Okay. All right. So that gives us pretty close to where things were when we removed the central. So now I'm going to take out the lateral. And again, on this case, we're removing all 14 uppers. In other cases where teeth are already missing, then you are following the line or the arc and angles of the setup as things progress. Okay, so I'm going in, okay, and I'm gonna assume this patient wanted to improve their smile line slightly and fix some of the character, some of the crowding or turning of the teeth. So I'm going to come in. I always like to lay my thumb on this too, so that then I just get a little bit of an idea of what it looks like beneath the lips. So my finger is going to pretend it's the lip. And what I'm trying to do is then see it within the frame of the face. So I'm pretending that my thumb is the lip, and now here's the frame of the face. So I'm checking, my edges and contouring to see, okay, this is where I'm going with this setup. And you can see now that I'm following things, and I like to do that. It's just a little trick that I've picked up along the way. So as we follow through, if you have any questions, please type them into the box for Jim, and he will either ask me at the end, or he also has permission to come and interrupt me as we go, so that we can talk about it as we go. So you can also see here from the profile here, as I'm removing a little bit of the supporting structure, it thins out, but you can actually still see the supporting bone here and here. So these are things that I'm going to relieve on the inside of the denture once it's processed, just slightly, okay, to relieve a little bit of that pressure. Because again, things are going to be pretty swollen and such when the teeth are coming out. And so that's okay to loosen it a little bit, because again, we typically see those pressure areas, and especially here, we're going to get sores here, and they're painful for patients. You can see the skin get abraded away. So that's why, again, I relieve into that area. Okay. So then coming through, again, on the cuspid, watching where the rugae goes, then I know that my cuspid is in the right placement. Okay. So now I'm going to take out that cuspid. So we're going to do one side at a time. Now this is actually great, because you can see on this model, as I've removed the cuspid, you can see the positioning and how the first premolars or first bicuspids are interdigitating. So that's actually quite helpful for later. So again, with immediate dentures, you do get this, I'll call it, it's a mixed bag. It's very, can be varied in terms of the condition of the teeth and how flat they are. So you have to keep this in mind when you're doing this setup, regardless, again, technician or denturist. Please keep in mind, if the teeth are flatter when they are being extracted and there's a lot of wear, then that person's going to have a flatter chew cycle, because they're, again, chewing with flatter teeth. So to do that and be effective, they have to mill it. And so they're milling their food. And when you mill, you have to go more horizontal. So that's going to be the brain's first response in all this. Once the teeth are pulled, is they're going to want to mill. But if you put in nice new denture teeth, what's going to happen then is they're not flatter, and they're not going to rest against the bottom dentition as well. And what's going to happen is then they're going to interfere, and the denture rocks loose. So the one thing that I struggled with early in my career was I would use flatter denture teeth if it was a flatter, lower natural occlusion. And I've really gone away from that, because I've tried to stay focused to the chew cycle and trying to take advantage of a cusped anatomical tooth. And I've become successful at it. Every case is unique and different. So this one has a nice natural dentition on it, which we can follow. So I wanted to do that today, just as our base. The consideration is when you get flatter denture teeth, like on this case here, where we see these types of divots and wears, and the tooth has compressed and moved. These are awesome, because typically we would want to follow. And as I snuggle this up, and let me turn the light on to get a little bit of a better, and then I'm going to tip it. And you can see the surface area of this tooth. I want a cusp right in there. So right into that fossa, I want a cusp in there. I want an opposing cusp right here, because this is where these things are going to come in and chew, okay? And then right back here is where I'm going to want contact. So I'm still going to take an anatomical tooth like a 22L lingo form, and I'm going to modify it so that the main cusp sits in here, secondary in here, so that we are taking advantage of these little pockets. So what these little pockets are is it's a bowl. So this is like a mortar and pestle type of thing. So again, you've got the mortar and pestle, and the tooth is in there doing this, and it's mincing and mashing and crushing the food. The reason why I follow that, everyone, and have gone away from flat denture teeth is because of the fit issues afterwards, where a patient says, it takes me so long to eat, and it takes me so long to chew. And then the big one, I can't eat lettuce. That was because, again, when we use like a flatter tooth or a 20-degree or a 10-degree tooth against a flatter dentition, thinking that was the right call, it's two flat objects trying to, again, you're not going to mince, you're going to mill, and it's not as effective. So what I'm trying to do is to take the anatomical tooth on an anatomical tooth, like a lingo form, and then modify it slightly so it sits into these little pockets that help crush. When I started to do that, I eliminated the I can't eat lettuce, and I eliminated the it takes me so long to eat, because I'm leveraging all that I can out of looking out and leveraging everything that I can here to help me so that it needs less chews to chew the food. It's been quite remarkable, because I had to rethink occlusion, and that's what I'm sharing with you today. And it's a rethink for me on how to set denture teeth and why I set them differently. So I'm just grinding the basal area of the cuspid out a little bit, and I am going to come in here. Okay, there. All right. So I made it a little bit more pretty. Let me turn the light back on. Okay, we come in, and I'm following somewhat of the lines of where things are. So we have an indent here. Okay, so we're going to have a little bit more gapping and then less here. So when I started this process, I was also watching the wear patterns. And so then remember, there was a wear pattern on this tooth as well. And now we don't have that wear pattern anymore on the denture tooth. So if we got to be careful, because the patient may not want that wear pattern there, but I know it exists, and I know it's going to exist here. So then I can make adjustments later when I start tinkering with the chew cycle. So I'll show you what that looks like once we get the setup completed, okay? So now I'm going to kind of go, and I'm going to carry on here to the posterior tooth, okay? And then I'm going to just remove these. But before we do that, let me turn and just show you again. So I always take a look. This is more of a tooth-to-tooth relationship. See, tooth-to-tooth versus tooth by tooth. So I'm going to try to maintain a tooth-to-tooth relationship here as we go through, because again, golden proportioned for this patient. So I'm trying to keep things as to where nature-ish has put it. So the other thing to keep in mind is typically we'll grab some teeth, and I've gotten into the habit of trying to mimic so that sometimes everything isn't golden proportioned, and you have teeth that actually are different sizes. So then I go and I pick out a tooth that's sized to this. And even if I have to start splitting up cards, I do that. After a while, then you get a whole bunch of spare teeth. And then I fit to what's down here, not just what was off the card. So if something needs to be bigger or smaller, I'm going to make that adjustment already for the case, okay? And so that it's going to fit and function better for that person. Again, all of this in efforts to control the adjustment rate. So I needed to take a little bit off the basal of the tooth just to thin it down so it sits into the pocket a little bit better. Okay. And now we're going to come in and seat the tooth into place. And then I want to talk a little bit about some of the occlusion aspects of it, okay? So it needs just a little bit more taken off the basal. Okay, now what I'm going to do is typically we would get our articulating paper out, and I don't like using articulating paper because it bends. So what we're going to do is we're going to start taking the tooth, and I'm going to color the tooth. Oh, how about if I show you what I'm doing? There we go. I'm going to color the tooth, and I'm using a non-permanent pen. Okay, so it's a Staedtler non-permanent or a Sharpie non-permanent. Okay, and then what I'm going to do is I'm going to tap it into position, and then what you're going to see is you can see the mark. Let me focus. You can see the mark in there. So what happens is when I don't use articulating paper, then I'm not getting all of these other wrong or where the paper bends and I get these deflective readings. This is giving me the true reading of the tooth of where it's sitting. Okay, and then actually what you can even see is a lot of times the ink will come away even on the tooth of where the corresponding cusp is hitting on it. So it's really accurate and fine when I go in there and I'm checking it like that. And you can see now where it's marking, and I can see where the position is. And I also want to go in there and check that dorsally as well when it comes in. So those are some of the finites of me doing that, where I'm very, very selective and careful when I start cutting the tooth. Being honest, when I was fresh in the industry and new in the industry, yeah, I would take a tooth and you just cut and slap it and get her done, and get it to fit. And now I'm very precise on what I do. I don't want to cut away anything I don't have to. I'm doing this because if I'm rushed, or if I just want to get the maximum contact, what I've learned is that comes to bite me later on in adjustments and patient acceptance of the denture. And they're coming back. And my chair time is way more expensive than this time when I'm tying up my chair time. So for all the dental technicians listening, why you do this is to help the dentist save chair time. All the denturists listening, why you do this is you're saving yourself stress and chair time, and stress dealing with the common denture complaints that we see, okay? So this is about just a little bit more fine work and finite work here while we build it, so that I'm trying to save myself hassle later once it goes in the mouth. Okay, so I got to adjust the tooth, so I'm going to take that off a little bit. So just the neck is too long. So again, I'm going to come in, I'm going to color the tooth. Tap down, and you can see as I bring this down and into focus for you, and there we go. You can now start to see where the marks are. This is awesome. Okay, and where I'm going and where the teeth are going. Okay, so if necessary, then I can take it, and you can actually see now that's marked in here. So I can take and I can adjust the occlusal surface of the tooth, okay? and I can go in carefully and just adjust it out a little bit to create a better fitting surface again. And then I'm going to recolor. And the beauty of the VITA lingoform teeth is they are made from acrylic glass, and I don't need to repolish them after like you would a acrylic tooth. Okay, and the reason being is the acrylic glass self-polishes. Okay, so I'm coming in and I'm checking and I'm keeping a tooth-to-tooth relationship. Okay. So I'm using a burr to trough out the tooth and keep a small indent in there. Okay, so I'm going to cut the neck off on the molar as well a little bit. And I'm still on a tooth over tooth relationship. So forgive me, I'm just going to heat up the wax here. So I'm just going to be off camera a little bit. One moment for me, as I just need to get some things softened in here and into better position. Okay. Okay, so I'm coming in tooth over tooth, very similar. And then I'm going to color. Okay. And then I'm going to look, and then I'm going to say, okay, whoops, let me go. And you can start to see some of the contacts develop. Let me hit focus again. Let me try that again. There we go. So I actually want this moved over a little bit. Okay, but we're starting to get into the fossa of the tooth, which is where I want the cusp. So now I can make some correction on that. So bear with me. So then when I color everything, it just washes off afterwards. Right. Okay, so then again, I'm just trying to take it and I'm moving it over a little bit. I'm just gonna go off camera again for a moment. Okay. Okay. Okay, this might be hard to see on the camera, so bear with me. I'm gonna try to snug in as best as I can, and I've turned the light on. Let me get something to point with. You can see this little mark right there. So what that is that's the denture tooth hitting. So I'm gonna go and I'm gonna take this and I'm gonna take this out, which is gonna close up the occlusion a little bit. So this is letting me finite see these little marks that I can now adjust on the tooth. And again, I'm only then adjusting where I absolutely need to. The reason why I'm being strategic here and not just tap, 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 grind, 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 tap, 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 grind, grind, grind is I don't want a smooth surface. I just don't want it to be this flat bowl against a flat bowl, because again, what have I seen patients struggle with is chewing and chewing lettuce and chewing food, and it takes them longer to chew, and then they're overworking the muscle and the denture, and it becomes problematic in their ability to eat, because again, quality of chewing life for me, this is about quality of chewing life, quality of life. And so that little mark that you saw, let me just center up here. So that was this one right here. So that was that little part. Okay, so these little markings are making these little markings here. And as I adjust down and can get the tooth into a better position, it's creating a better, whoops, sorry, I'm off camera, taking a better better position on the tooth and better contact. And then what's happening, and I'm going to try to snuggle in so you can see this, so bear with me. Okay, let me just, what's happening as this develops is these buccal cusps are hanging down, and it's not this flat look. When I hold my thumb and I'm pretending there's a lip, it's also following through through the little black triangle here, and the cusps are hanging down, and it's not this flat look. You can see the emergence profile of the teeth. So this is from an aesthetical perspective. We're trying to give them an immediate denture that doesn't look like an immediate denture and doesn't look fake. And we can do that. And we are able to do that. Okay, I'm gonna go off camera one moment. Okay. Okay, so I'm just gonna still stick with the tooth over tooth relationship. I'm gonna color. Okay, and so again, I'm trying to achieve the tooth. So I need to do a little bit of an adjustment on the tooth. Bear with me, off camera. Okay. Now, this is a fairly large second molar. Okay, let me take that. It's a fairly large second molar. Okay, gosh, it's about the same size than the first molar. And so I've just now, gone in and used a second molar, and it's coming across as really small, which means it's not covering the tooth as well. So I'm actually going to take this tooth out, and I'm going to grab another molar. So forgive me, I'm just going to take the neck of it off a little bit. And I'm actually grabbing a molar, and I'm going to put a molar in that. So the reason why is most of the chewing that gets done on the molar and second molar. That's the bulk of the chewing, and the chewing surface is on the molar and second molars. There's a little bit on the second premolar, but most of it's on the molar and first molar and second molar. So I'm opting out now to use a larger tooth back there why efficiency, okay? Function, efficiency. The function and efficiency, circling back, is I'm trying to spend the time now, function and efficiency, so that they're not coming back afterwards for as many adjustments. So I need to cut a little more off the basal of the tooth just to thin the tooth out a little bit. So I just cut some off the surface area and then again back in. Okay, there we go. So now we're getting a better contact and it even looks better. It's not as dainty and small, okay? And it's gonna rest in better as I recolor everything here. Okay, and I'm getting better contact now with the cusps. So then I can just take some type of a wet cloth or Kleenex, and you see the color comes off the teeth. And then I go to the sink with a brush and the color just comes right off, okay? It was a little bit of an adjustment to get rid of and stop using articulating paper, I have to say. But now that I use it less and less, I'm much happier. So you can see down the emergence profile of things that we have cusped here and then we have cusped here, and it's not looking artificial. And that's what the patient wants. They don't want to look like a denture. I have to say that on immediate dentures as well, it's can be quite a traumatic experience for people. I have had women openly weep in the patient chair because they're having their teeth pulled. It's a big deal. And so regardless of where you are in the chain of this, so a technician or a denturist, there's a person on the other end of this thing, and they're upset because they're getting their teeth pulled. Okay, and it's a big deal. So everything that we can do to try and help that transition and help it so that they are more comfortable, it's a good thing, because this is about patient care. And even the technician that's underneath the dentist holding that dentist up, it's important, because when the patient's happy, the dentist and the doctor's happy, and when they're happy, then they keep sending work to the lab because, geez, the lab does good work. And that's how you build your reputation, sitting on the bench. Okay, so now we're going to flip and we're going to do the other side. So we have about 30 minutes left. So my goal within the 30-minute time allotment here is to get the other side set up, and then just show you some of the movements associated with the articulator and moving the articulator. So forgive me as I'm just working a little off camera for a moment. I'm coming back into camera right away. I'll just take a little bit off the length of the tooth. Okay, and I'm gonna come in. So we're gonna straighten some things out here and just help out with the setup, with the intent of fixing some of the teeth that had some character on them. So excelled denture teeth have no neck on them, so we don't have to worry about a neck exposing the neck, cutting away the neck, etc. So that was done with intent, so it's customizable. Okay, and that's the beauty of it now, is I love working with with denture teeth without a neck on them because the neck isn't necessary anymore. I'm just going to seal that down so it doesn't move. Now we're going to come in with our lateral here. And then we're just going to keep that lateral a little straighter, keeping in mind that that tooth too had that wear pattern against this lower lateral as well. Okay, so depending on the person and if because I have the privilege of seeing them, I might even just flatten that a little bit to make it a little bit more correspondent to this one. Okay. It's an option that I can do without damaging the tooth and affecting it too much, but that's just, I like to discuss that with the patient if at all possible. Okay, we're going to carry on to the cuspid. Okay, I'm going to cut a little bit off the base of the cuspid. And then I'm gonna, so then the goal then is to follow the rugae, that the rugae is gonna point to the cuspid. So regardless of again, what's included or not included for denture, or excuse me, for natural dentition, when you're doing an immediate, you always wanna circle back. Okay, so because I know I just cut this tooth off, it's going in the same position, so I'm gonna be following these lines. But with that said, if the tooth is already missing, you're using the rugae just to keep yourself orientated of where you're at in regards to the golden proportion rule, to making sure that everything's going to be lining up correctly. Okay. So again, the decisions that I'm making are to, again, always circling back to quality of chewing life, quality of life, reduction of an adjustment based on the common denture complaints that we see regarding ill fit, and especially on the immediate denture, because the patient has to spend considerable amount of time now learning to chew with something they can't feel. And in terms of the denture teeth not feeling, this denture will be pushing on the gum structure. That gum structure needs to heal sufficiently, pardon me, to allow the ability to understand the pressure change. So all the nerve endings and tissue needs to, and the mucosa needs to heal. So when we give them a denture that fits and is functioning more in line with the parameters and the chew cycle and the parameters of the lower in terms of the wear patterns and things that we see, that's helping the patient adapt to the denture better, because I'm trying to make this more customized to the patient and not cookie cutter. And that's why, again, you see me my different philosophy of coloring the teeth versus just using articulating paper and whack and just grind heavy and get her done. I appreciate this. You can work quickly and expediently as well on the bench. I appreciate the, having worked in large commercial labs, I appreciate, the stresses that are there. You can work quick and fast to this as well. And what you're trying to do always is support the doctor, because again, what you're trying to do is have this patient come back less. When they come back less, the doctor's happy with the lab, because why? Well, the stuff they build fits. And so again, as denturist, if you can cut your adjustment rate down by half, that means something, okay? Because now you're not as overloaded every day. That's been a big aha moment for me, is the understanding of why I do this and why I show you I do this is the quality of chewing life and getting a control of my adjustment rate and bringing it down. And even on an immediate denture, you can bring it down to manageable levels. So I'm taking and cutting them again, the tooth down a little bit so that it fits in. And we can get that lined up in there. Okay. And I'm keeping that tooth to tooth relationship as best as I can. So that's that mark right there. So that's reasonable. That's going to be the cutter, and it's coming and it's resting in right in here. Okay. So I can just fiddle with this a little. Sorry, I have to bring it closer to my eyes. All right. Come in. Okay. All right. I'm going to cut the molar and second molar off, so I just need a minute. All right, let's get those last two teeth in. Okay, so on this case, we saw some wear patterns. There was some wear pattern on the cuspids. There was some wear patterns in regards to the laterals on the upper. So we knew that there was a little bit of a little bit more of a horizontal draw on this. Okay, so I'm going to cut the basal of this tooth. Still keeping the tooth to tooth relationship that was there originally with this patient. Coming through with the ink. Okay, so I want a little bit better than that. So I need to reposition a little bit. So I need to cut some more of the neck off. That's what's holding the tooth back. There we go. And I'm just going to look down the dorsal off camera. There we go. That's better. Okay. So that's coming in now. So we can start to see that there's some marks coming in here, which is where I want them. It's going to be a little tough to see down the dorsal here. Let me just turn the light on, hit the focus button. But you can start to see like we're getting that decent contact in here, and I want to see gapping. Is the other thing that in early on in my career, I was looking for these tight spaces. No, because what happens is when everything's tight, when you come together and touch, it squishes the food off. You want the food to stay on the teeth. The job of the lower is to bring the food to the upper to get crushed. When everything is so tight and the food gets pushed off right away, it's not efficient. You do want the little gapping to allow the food to stay on here to get brought up to get crushed. So I was used to, when I left school, wanting these really tight looking occlusion, and it's not something that I reproduce today. And it's not something that I reproduce today for the reasons that we've been chatting about now, from the efficiency perspective and from getting away from a milling type of perspective of a tooth to a crushing tooth to a mortal and pestle. Okay. So I used a first molar as well again here, so that it was a little bit larger due to the size of the lower. Nice. Okay, so that's fitting in not bad. Okay. So I can make just a little bit of adjustment on the tooth here. Okay. Okay, sitting in better. Okay. Okay. Now I'm just going to tip that back a little bit and into better position. There we go. Okay. Now, allow me a moment. So typically then you can just go to the sink and this washes off. So what I'm following on now is I'm going to put my fingers here like the lips so that now you can see, again, these are not mirror opposites. They have golden proportions. What I like is now you can see the nice emergence profile and the cusps come all the way along. So it's not screaming denture. Okay. You have to appreciate a lot of times people are coming into the dental office to have their teeth pulled and they've let things go for a while. So of course, when you see it, it's a mess and it's worn down and stuff, but the patient is also finally accepting that they want to do something and they want to make a change and make a difference. And what they're trying to do is now improve their quality of life and their smile. And that's really important because now we can give that to them and not give them the denture look. We are giving them a customized golden proportioned denture to their face and helping them rehabilitate their smile back, because then it's not the stigma of, well, it's a denture. They're actually happy to wear it and that it's functioning, but it's also attractive and aesthetic for them. So what I'm doing now is I'm coming in and I'm going to color. We have about 10, 15 minutes left. So this was quick. What I'm going to do now is open the articulator to function. And remember now, before I noticed those wear patterns. So now instead of the typical, so I'm going to hold it down, I'm not doing this at all. I'm doing that wear pattern. So I knew where the wear patterns were, okay? And so I'm horizontaling this out a little bit, okay, to mimic that wear pattern here and that wear pattern here where there was that rise up, okay? And then what that's doing is that's marking along here, you can see it. And then now I can actually take it and you can see there's these little, let me focus, that always helps. Sometimes it's hard for the camera. You can see these little lines where this has been pushed away, and that's the incline of the tooth hitting on those areas. So now I can take a finite burr, okay, and I'm going to just go in there and grind away those guiding planes slightly on those teeth to just facilitate the chew pattern. Does that make sense, everyone? If you have a question, type it in because we'll go to the question and answer right away. And that's how I check it. Okay. As my molar fell off, but anyway. Okay. So then I can see the marks here, and then I can actually see the marks come off the tooth. So what I did was I followed, you know, when we started this, I did a mall analysis, checked golden proportions, then assessed the wear pattern on the natural dentition to tell me then what the chew pattern was like without seeing the person. And then as I finish the setup, I'm modifying the chew pattern to that, and then modifying the teeth to that based on what I see from the wear patterns. Then I'm moving my articulator more in line with the chew cycle of the person. So that gives me a customizable denture that's, again, circling back to our main treatment goals, which was quality of chewing life and quality of life for the practitioner. I am trying to reduce the adjustment rate needed and necessary, especially for these types of dentures. And I'm trying to help the denture integrate better into the body and into the person. So my goal was to give you, my experience and how I tackle these types of issues and these situations in my office to do that, to adjust and get control of immediate dentures so they're not as scary and they're not as scary for the patient. I also wanted to address with you and bring up, again, how I address it with the patient, especially regarding the denture integration into the body. There's no nerves, hydraulics. When you talk to someone like that, the patient, I mean, boy, they appreciate your knowledge level when you start talking about hydraulics and how the denture is going to sit in, and they're very appreciative of that, because you always can cycle back to that and remind them, and they appreciate that because of their trust level in you. And these are conversations then that you can have with the doctor to provide tips, or for those denturists that are joining us today, to your patients. That's been valuable for me, so valuable. Okay, Jim, do we have any questions?
We do have some
Hi, Jim.
questions, so let's, hi Mark, good job. So let me come back. Let me bring back my screen for a second.
Okay, Jim's going to assume control, everyone.
All right, for those of you that have been inquiring about CE, through your registration, we'll use that information. Marking will send you out an email. And what we do is we will automatically submit to NBC. If you're Florida, then if you need a letter, just request one, and we'll get that to you as well. So the workshop itself, the webinar, has been recorded. It'll be buttoned up and then loaded onto the VITA North America YouTube channel in a couple of days, so please visit it. And then we have, if you need to get a hold of anyone at the help desk, here is those numbers, and I'll come back to it as well. If you need to get a hold of the local rep, we have the rep's information on this screen, and you'll be able to see that on the recorded video as well. Visit us for some more additional webinars, all sorts of topics. Mark's got plenty to go. He also has an actual, what we call a remote workshop that we scheduled. So we are going to do, send out a model set to you, and then we would send out the teeth, and you would do everything in your lab, and then Mark would take 2 days to go over it. We take about 3 hours per day, 2 to 3 hours per day, for 2 days right in a row, and we do a remote one where you actually get experience while you're at the lab with your own personal articulator, your own tool set, and everything like that. So please join us for one of those features. And then Mark is gracious enough, if you need to follow up with Mark himself and have a question or something that you need to elaborate with him on, please feel free to give him an email. You might want to email him first, say when he's, ask him when he's available, and then go ahead and get a hold of him. He does have a working lavatory denturist clinic, so please keep that in mind, that he is sometimes busy and so forth. So, and then we have a couple of questions. Let's see. Any changes when you do upper and lower denture? So no. I'm not sure if that's, okay.
Other than from the occlusal perspective, I'm not really grinding on the occlusion per se. I'm setting the teeth into position, upper and lower, following plane of occlusion, 2/3 up the retromolar pad, And then from an upper and lower perspective, just making sure again that the teeth are functioning within that chew cycle, adjusting out any guiding planes based on what I think that chew cycle is going to be from either interacting with the patient or looking at the dentition that I'm removing and replacing. Then that tells me, is it more horizontal or is it more teardrop? I can make those changes. Again, why? Reducing the adjustment, better denture integration into the body, less stress for us. We have enough stress in our life. And again,
sure.
this is and this is about, thank you, and this is about cutting down on the adjustment rate and controlling it better. So it's very similar. Following again model analysis. Sorry, Jim, carry on.
Speaking of adjusting your guide planes or just in general adjusting your teeth, the question is, after you adjust them, do you have to polish them?
No, not on Lingoform. No, because it's acrylic glass. So VITA Excel and Lingoform are made from acrylic glass. You do not need to polish that after. It's self-polishing because of the glass particles in it. So that's why that's why I've migrated to this and migrated to this product, because it's saving me time. I don't need to, because you and I both know polishing teeth afterwards is tedious. So, no thanks. And this has been awesome for me from that perspective. I can make these adjustments, use a fine burr, a diamond burr, a rubber wheel to make your adjustments. You don't have to polish after.
All right. So when you have the upper that's posing natural teeth, if for some reason your lower natural teeth go above the occlusal plane, do you follow that with the upper, or do you adjust the lower natural teeth, or do you leave the natural teeth intact? How do you compensate for irregular occlusal plane?
Right. So if it's an upper denture to lower natural teeth, you got to follow it. And I try not to have things dip too much if necessary. So sometimes my contact points are just a cusp contacting against the lower antagonist. And in other cases, then I try to make sure I have better contacts elsewhere so that you don't have a tooth dipping down that looks unsightly. But you have to make up for it somewhere so they chew better and have a better contact point. If it's an upper and lower, then because the teeth are being removed top and bottom, then I have a little bit more wiggle room. If sometimes I can lower it or lift it as required, because I've taken the teeth out of play, and then I just have to grind the basal aspect of the tooth more on one arch or the other.
Right. And then do you always set the teeth a 1-to-1, never a 1-to-2?
Right. So on this case, that was me looking at what nature gave that person, and then I was copying it and mimicking it, because then that was golden proportion for them. So yes, I kept it 1-to-1. Typically I'm more of a 1-to-1 guy. Yes. My goal is to find the cusps and place them into the corresponding antagonist fossa, and that's usually a 1-to-1 situation.
All right. And what's possible to do when the patient comes to the office with an old denture, or his teeth were pulled a while ago, and he's not happy with his old denture? So
What's the question? What do I do?
So yeah, what's possible?
What's
when
possible?
They come to the office with an old full upper lower denture?
Yeah, and they were immediate, and they're
teeth
mad.
were pulled. Yeah, immediately pulled, but a while ago.
Yeah, say 6
months. He's not happy with his old denture.
Right. Okay, so let's
start from new, right? Pretty much.
Well, let's speak candidly. I had a patient not even 3 weeks ago. We just finished treatment on him. Same problem. He had 3 sets of dentures made. So the first one was an immediate, and then it wasn't working. So then the practitioner made it again. It didn't work, and then they made it again, and it didn't work. So then by that point, the patient's frustrated and hungry, and then they sought me out for treatment. So putting some of the ethics aside for a minute, once we settled things and the patient was brought on board properly and onboarded properly here, the old dentures tell a story. Look at them. Why are they failing? I ask, what couldn't you do? What do you mean you can't eat? Because they say, well, I can't chew. What does that mean to you? Because again, hot coffee to Jim and hot coffee to me are two different things. Spicy to Jim and spicy to me are two different things. When they say to you, I can't eat or it's not working, you have to say, please be descriptive. And then you try to let them be descriptive. A lot of times they just say it just doesn't work. I can't do it. And they don't have the words, but what you're trying to do is to get them to think, because then I follow it up with this. Okay, Mr. Smith, let's talk. The whole purpose of teeth is your front teeth bite off food, and then your back teeth mince it. And when they're mincing the food and pulverizing it, they're mixing it with saliva, and then that sticks it together into a ball. That ball we call a bolus, and then you swallow that ball down, and your esophagus squeezes it down. So teeth are there to bite off, mince, form it into a ball, and you swallow the ball. Can you do that? No, I can't. That's right. So now you've taken them, so you've let them say it in layman's terms. Now you've taken it into dental terms for them. Show them that you understand the process, so you're building that trust level, because the trust level's been broken with the other practitioner and with their experience. And now you say, okay, well, what we need to do is reestablish now that process. So now I get into the whole teeth and nerves and denture integration. So I usually book an hour and a half for those adjustments. And then I look at the old dentures and I'm making a critical adjustment of, well, what's wrong with them? Like, are the flanges extended? Like, what do I see that it tells a story of where the failure was in all this? And then we craft a new denture. So typically I'm not adjusting the old one, but it's told me a story of where the failure was for helping me manage that and the expectation levels of it. Because again, if a patient says, well, I take my tongue and do that, well, sir, you're going to do that. You'll do that on my denture. Even if I shake my head, my glasses are coming off. You know, the eyeglass place can't stop that, can they? So it's also setting that expectations that may not have been properly explained to the patient. And you got to keep in mind at this point, they're frustrated, they're hungry. So, you know, we got to be careful because they're looking for that magic. And so a lot of times I'm very careful. And I give them a written document after of what we spoke to so that everything goes into writing. That's really important. So I hope that answers your question. I'm trying to reestablish their chew cycle and that mincing, rolling into a ball and swallowing. And you do that by mincing, not milling. And that's why I use anatomical teeth. And that's why I use these guys and lingo form, is because it allows me to do that. And the patient can chew lettuce and eat lettuce and function better and have that quality of life.
We got a couple of questions again. Just remind him what articulator do you like and the reason for it.
I use a Cavo Protar 7. I like that because it can move and it has the freedom built into it. So I like that articulator. It's built by a medical engineer, very smart man by the name of Walter Lang, and that's the articulator I use. But honestly, you can still gain same effects with a hinge articulator. Just use it in different. I'm showing you. Just operate it differently. Follow a chew cycle.
And then we have. Do you always use go one size up for the molar, or was that just dictated by the case again?
That was dictated by the case. Yes.
Okay.
Yeah.
All right. Well.
Cool.
That looks like it, unless there's last minute questions if you want to get them in.
But
that'll wrap up today's webinar.
Yeah. Look, contact me privately we're here to support you and your growth as practitioners or as denture professionals, whether you're on the bench or whether you see patients. This is about us sharing knowledge and growing together as a community and a dental community, supporting each other, because again, what we're trying to do is be superheroes to that patient, whether we see them or not directly. So again, very thankful to VITA North America, especially to Jim for their hard work and preparation and planning and all this, and their kind support of our industry and profession. And thank you to you for taking time out of your busy days to join me and hear me out in my journey. And my goal was to poke and push a little bit to have you think differently and approach it a little differently with always the mindset of quality of chewing life, quality of life for the practitioner. So we're not dealing with the same BS day after day. We can get better control of it. But again, trying to be that superhero that drew us into this profession. And so thank you very much for your time.
Well, thank you, Mark. Appreciate all the knowledge that you provide everyone. And I know that they'll be back on the next time as well.
Thanks.
So appreciate your time. Thank you, everyone, for joining us today for another VITA Academy webinar. Awesome. And this will conclude today's webinar.
Awesome. Bye, everyone. Thank you.